All right, so I think we can go ahead and get started. Welcome everybody. Thanks so much for coming. This is the webinar series, Vaccinating the Country Against the Novel Coronavirus. And this session will be focusing on reaching marginalized populations. And we've got an amazing group of people here, experts, who are gonna help lead us through this very complicated challenge that we're faced with as a country. My name is Abraar Karan. I'm an internal medicine physician at Brigham and Women's Hospital and Harvard Medical School. I've been working on the COVID pandemic since February with the Department of Public Health at Massachusetts State and with WHO as well on the independent panel for pandemic preparedness and response. I'm going to go ahead and just do a sort of brief intro to some of our expert panelists, and then we'll let the panelists go into a little bit more detail, and then we'll address a few questions that will help guide our discussion. So we are very lucky to have Dr. Céline Gounder, who is a clinical assistant professor at the Department of Medicine at NYU Grossman School of Medicine, Bellevue Hospital, also host of the Epidemic and American Diagnosis podcast, and a member of President-elect Joe Biden's COVID-19 task force. Dr. Kamara Phyllis-Jones, who is a family physician, epidemiologist, and past president of the American Public Health Association. Ms. Shalini Pummel, healthcare strategist and movement builder. She focuses on health policy, healthcare delivery, and financing, has worked as a management consultant in a number of strategic advisory roles with grassroots campaigns, such as with Doctors for America, Doctors for Biden as a strategy director, and also with Surgeon General Vivek Murthy in 2014. And Dr. Brian Williams, who is a military vet, now serving as an associate professor of trauma and acute care surgery at the University of Chicago. Dr. Williams graduated from the U.S. Air Force Academy, the University of South Florida, Morsani College of Medicine, and completed his general surgery residency at Harvard Medical School with a fellowship in trauma and surgical crit care at Emory University in Atlanta. So with that, I'm going to turn it over to the panelists. We'll maybe start with Dr. Jones, if you can give us a little bit of more detailed background, and then we'll kind of go around with the group and then go to questions.
Okay, and Dr. Karan, do you want some one or two points to throw into the pot for our conversation now?
Absolutely. I think maybe if you can bring up one or two points that you think are very important to kind of get out to the viewers.
Thank you. Yes. Well, so I am Dr. Kamara Jones. My work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. And as we enter this conversation, I just have a few points to raise. One is that I don't think we need to be coaxing or cajoling or convincing anybody to take the vaccine. I think we have to recognize that people's questions are legitimate. And what we need to do is be answering their questions with answers that might include, I don't know, or we don't know yet. That's the first thing. The second thing is, I took the vaccine last Saturday. I was so happy. I was scrapping, trying to, when my turn came. And the reason is a risk-benefit ratio. So I will put myself as an example that, and we can talk about that later, but the vaccine is just one more tool in our individual and community toolboxes. So, you know, the masking is a tool that protects individuals, but even protects more of the community. Vaccines are a tool that actually protect the individual more, but a little bit the community. But the third point is that we cannot vaccine our way out of the raging pandemic that we see right now, that we have to public health our way out of this. We have to put all of the individual and governmental public health strategies in place that we can as we gradually, one by one, vaccinate people. And so I'm reserving some time for our later discussion to talk about the difference between exponential spread and arithmetic spread.
Thank you. Thank you so much. And I'm going to go kind of in order of my screen. So if we can have Shalini go next.
Sure. Thank you very much. It is such an honor to lend my voice to this dialogue and accompany such brilliant physicians and public health leaders, all of whom I admire your work greatly. So thank you. So my perspective and the lens through which I think about this issue is informed by over a decade of community organizing and health advocacy experiences. So my journey began as a leader in Doctors for America while I was an undergrad at Harvard. I served as a board member of Doctors for America and then continued on into grassroots movement work with Vivek Murthy to confirm him as Surgeon General, and thereafter with Doctors for Biden and Vote Health 2020, both of which were civic engagement and education campaigns of this past year. And throughout all of these public health and advocacy efforts, my endeavor in public health work is to uplift the stories of marginalized communities so that we understand the realities faced by these communities and do so with a compassionate and informed lens so that the science and the knowledge of our medical and public health experts can effectively meet the moment and meet the realities experienced by these communities. I mean, particularly with COVID-19, this has been vitally important as civic engagement also needed to be addressed with an eye towards all of the factors that make this moment more challenging: housing security, job security, financial security, food security. And for me as a public health scholar, I'm always attuned to those factors which contribute to the wholeness of an individual and of communities. And I think that's the most important thing right now. Lastly, I think the effort to educate, to inform, to inspire, all of that requires a commitment to making the process of engagement and the cultural environment and the connection to information very transparent and very clear and very compassionate. And that's our charge when we consider all of the approaches at our disposal and all of the messages and all of the messengers that we have to vaccinate the entire country.
Thank you. Thank you so much. Dr. Williams?
Yeah, thank you for inviting me today. And I'm looking forward to not only contributing, but learning from all these esteemed panelists today. So it's quite a treat for me. My journey, as you mentioned before, I'm prior Air Force. I did not plan to become a doctor. I was an aeronautical engineer, having quite a good time in the Air Force doing some testing work for the military when I decided to go into medical school. But what I carried with me from that was this ethos of service and serving a greater good. And that is something that kind of really guides me now throughout my career in medicine. As a trauma surgeon here in Southside Chicago, seeing a lot of gun violence, but also seeing the overlap with how this is affecting the same communities that are dying from COVID. And trying to use my experience and expertise to move beyond just being a clinician. And how do I collaborate with folks that are doing policy and business and other areas that are not necessarily within the hospital to actually transform the communities that we serve. So an opportunity like today is one of those opportunities, which I'm looking forward to. And just the overriding theme for me is when we're talking about vulnerable communities and the vaccine is that the vaccine is here, but not everybody can get to it. So availability does not equal access. That's what we need to address today and how we're going to eradicate that sort of chasm.
Thank you, Dr. Williams. And Dr. Gounder?
Hi, I'm Dr. Gounder. I spent the earlier part of my career working in HIV and tuberculosis, global health. Much of that time was spent in South Africa, in Soweto, but later on branched out to a number of other countries in the region. I also served as assistant commissioner at the New York City Department of Health, was an Ebola aid worker in Guinea for a couple months, and so certainly saw some of the challenges around trust, conspiracy theories and the like, and how that intersects with a pandemic, or in that case, it was an epidemic. You know, I think just to follow up on what Brian was just saying, access also does not equal shots in arms. And so what we're really dealing with here is a combination of, in terms of our vaccination rollout, challenges with supply, challenges with distribution, challenges with administration, and also challenges with demand. And the demand piece really relates to a very long history of justified distrust based on, and I've seen data now, having served on the Biden-Harris transition COVID advisory board, I've seen data from a number of different academic, private sector, and so on parties, and they basically are replicating the same results over and over again, which is that in particular, African-American and indigenous populations in this country are the ones that are the most likely to report that they do not plan to get vaccinated or are hesitant to get vaccinated. And Latinos and whites report about the same level of hesitancy, which is significantly less. And there's a very good reason why African Americans and indigenous people, it's because those are the people who historically were enslaved, who were subjected to medical experimentation and abuse. And so there's a very good reason why there's more distrust in those communities. And I do think, yes, I think the whole conversation about trusted messengers is an important one. It's something I believe in, but I feel like it's almost become a bit of a cliche where it's a way of papering over much deeper problems that you really have to acknowledge, and you have to provide real responses to, real fixes for. And no, those things are not going to be fixed overnight. But I think if you truly want to address those issues of distrust, it is going to mean real systemic change. Oh, and one other thing I just wanted to clarify, because this keeps on coming up over and over again. So I was a member of the Biden-Harris Biden-Harris transition COVID advisory board. So transition has now come to an end with inauguration. So our entire advisory board is no longer in existence. Dr. Kessler is joining the administration. Dr. Murthy is awaiting confirmation as Surgeon General, and Dr. Marcella Nunez-Smith will be joining the administration as head of the Equity Task Force. The rest of us are largely people from academia, from public health departments who are returning to our day jobs, but a subset of us are actually going to continue meeting informally and working on projects together moving forward. But the reason for a advisory board for the transition period is because the incoming administration did not have access to the CDC and FDA and NIH and so on experts. So we stood in for that until they could have access to internal government experts.
Thanks, Dr. Gounder, and thanks for that clarification for your work on the transition committee. Much appreciated. Before we move on, I just wanted to quickly acknowledge Doctors for America and the U.S. Public Interest Research Group that has sponsored this event. So kind of moving on to a topic that has been brought up now by everybody in different ways. So, it's interesting when I initially had some of these conversations with colleagues, the framing of this was that marginalized communities may not trust the medical system, rather than the framing being that the medical system itself is not trustworthy. This actually comes up in the global health setting as well, in a little bit of a different way, actually, where people talk about lower income countries or poor countries, rather than saying impoverished countries, which is the framing that we use in global health equity to say something happened to these countries that left them in this state. It wasn't just a state of being. Similarly, what role did the medical system play to lose that trust amongst communities that otherwise are very much about trust and community? So I wanted to talk about that a little bit in the sense that we knew this was an issue before COVID. What could we have done better? We've had the whole year that we knew vaccines were coming at some point. What could we have done as a medical system, as a public health system, to prepare better for when we actually had this supply and we were ready to go? And I'll leave it at that. So Dr. Jones, if you can get us started.
Yeah. I would love to jump in on that. That's an excellent framing of the question. What we could have done is shown that we valued Black and Indigenous and Latinx and Pacific Islander and other lives before we're just trying to convince them to take a vaccine. Because if you come to me now with a vaccine and say, here, take this, I'm wondering, are you just trying to use me to get to herd immunity so that your child can go to their beautiful school with all of their resources while my child is still struggling, right? So the thing is, show me that you value my life. What we could have done, it's not even about messaging about the vaccine, it's about pay most people, enable most people to be able to safely shelter in place. So, something like a universal basic income. We had the first $1,200, and we have the little $600 that we're going to augment now with 14 to bring it to 2,000. No, we need monthly payments so that people are not going to work just because they have to buy food or pay the rent. Not only extend the eviction and foreclosure moratorium, do rent forgiveness and mortgage forgiveness. Make, for those people who really are essential workers at the front lines, make sure that those workplaces are safe. So the Occupational Safety and Health Administration didn't do anything in terms of workplace safety regulations or enforcement with regard to COVID-19. Do that. And for those workers in those workplaces, make sure that we protect the workers. So if we have to invoke the Defense Production Act to create more PPE, right? Or more tests or more vaccines or all of the things that we're going to need, do that. But, you know, so, and implement a public health surveillance approach to testing. So we have real-time knowledge about how much how much virus is circulating. So what I'm saying is vaccine, it's a little late to come to me to try to convince me to take the vaccine when you haven't been caring about me the whole time. When in fact, when the government, the recognition came that it was Black and Indigenous and other people of color, folks who were more likely to get infected and more likely to die, that was when the then president said, well, you know, reopen Minnesota, reopen Michigan, reopen Virginia. Like, what is this? So I know we have a whole different administration, thank God. And we're all feeling a little more relaxed. But what we have to do is pick up on all of those things that did not happen. Don't just come to me with a vaccine now and you've been watching while my people have been dying.
Yeah, that's so true, Dr. Jones, so powerful. Thank you so much for that. Any other thoughts?
I would add to that, you know, one of the lessons I took from working on the ground during the Ebola epidemic was you really have to look more broadly at what it is that people need. And there was a lot of money that was flowing into Sierra Leone and Liberia and Guinea. And all of that money seemed to be going to either government officials or foreign aid workers. That was the impression of people on the ground. And so all of a sudden you had people driving around in 4x4s and, you know, that sort of thing. And people on the ground were like, well, wait, how is this helping me and my community? And, you know, I had a family I spoke to where half the family of 20 or so had been infected with Ebola. A number of researchers had come asking to collect convalescent plasma. And I had met them after this had happened. And they said to me, well, how is that helping me? And I think you have to understand that when you have a public health program like this, you really need to have employment of people from the community to serve the community with resources, building up the community. And it's not just about, yes, trusted messengers is part of it, because you want the vaccinator to be somebody that they trust and can be there to answer their questions. But it's actually bigger than that. It's really investing in those communities, creating jobs, creating opportunity, creating you know, a way out for people to have better health because they have better lives. And so I think, for example, with the 100,000 public health core that the new president has proposed, that should be an opportunity to create real jobs, real opportunities, real professions for people embedded in their communities. And I think that is a very important piece to addressing these longer term structural issues.
Shalini or Dr. Williams, any thoughts?
I can add to that as well. So we talked about the historical impact that's happened for Black patients and Indigenous peoples and how that informs what we're doing now. So there really is an obligation upon those of us in healthcare to prove that we're trustworthy. We've established that. But also, we're sitting around talking about what would increase their trustworthiness. It'd be great to hear one of their voices as well. So maybe having them on panels like this to inform us. We have our perspectives and our biases and our sources, but that is a pretty important voice to be heard as well. So hearing from all spectrum of folks that are involved with getting the vaccine out and who are actually taking it may help us to make better decisions going forward.
For sure. I would just echo all that. I think the one thing I would add is that in our framing of even this panel, when we talk about marginalization and marginalized communities, it almost suggests that this is a silent, like the fringe of society, wherein actually this is our majority, I would say. This is a silent majority that doesn't have a voice, that doesn't have a platform. And there's a quotation I always think of in that context, which is the measure of a society will be judged by how it treats its most vulnerable members. And if we think about the marginalized as our majority, and also extend that to marginalization when it comes to socioeconomic status, ability status, language status, immigration status, all of the isms that affect people and their experience of community and of humanity, then we start to look at the problem differently and also think about the interdisciplinary approach that is required. So when Dr. Gounder is talking about the jobs initiative, this is just as much a healthcare issue as it is a financial issue, as it is an issue that transcends all of the places we have siloed. And so I think that to reframe our thinking around it and also acknowledge that this is a multidimensional problem that requires interdisciplinary solutions, and that we can have humility in saying, like Dr. Jones started, I know what I know, and still I know what I don't know. And that's where we all, come together with a common goal. I think that is a big piece of the conversation.
And there was one little thing, one thread that we all know here, but some people don't. When they talk about the historical injustices, well, yeah, if you're talking about yesterday, if you're talking about, for example, what happened with Dr. Susan Moore, right? Or yes, if you're talking about what happened when I just tried to call, or, all of that. So all of it's not, the history is not a long time ago. We have to dredge it up. We are living the disregard of so many of us daily. And so just that, the trustworthiness has to be an evidencing, oops, well, there goes my camera. I'll try to bring it back, but my Zoom is really weird. So if I go out, I hope that you guys can still hear me. But
you're back.
Okay, so it has to be, I guess, the deep investment and the deep valuation, the deep valuing of all of us, not toleration of us.
Yeah, thank you to all of the panelists. Just really hit some key points there. So I'm going to move the conversation a little bit further now. So, what is our current understanding of what the sources of mistrust are? Whether that is from things that happened yesterday, things that happened months ago, things that happened years ago, centuries ago, et cetera. What is our current understanding of that, and what are some strategies at the community level that you all have found to be helpful to overcome some of those questions? And those questions come from all places, even within the healthcare system, from fellow physicians, from people really at all different levels of educational background, different experiences. And as some of you may have noticed, there's been a lot of sort of stigma, particularly at the healthcare level, to say, I can't believe healthcare workers would have questions about this vaccine, when in fact, if you think about the hospital itself is suffering from racism, classism, and all the sort of isms that you see in society. The hospital employs a number of different people, and those people are treated in different ways. One recent example was that some hospitals noted that the janitorial staff didn't have access to the email that sort of went out to say when vaccinations were happening. That's one example of many. A lot of these communications are primarily English focused. They're primarily focused on people that use technology in certain ways, and that is a sign of privilege in itself. So what is our current understanding of a couple of those issues? And I'll let whoever wants to kind of jump in.
Well, I think you touched upon the importance of not using monolithic terms when we describe those that are receiving the vaccines. And healthcare is a perfect example of that, right? Because if you're not in healthcare, you would assume that, of course, if we have access to the vaccine, we would all get it, right? But the healthcare system has tens of thousands of people from all different walks of life, down from your, like you said, your environmental staff up to the CEO. So they may have different opinions about whether or not they should get the vaccine, from frontline workers to essential workers to administrations. So that same sort of variability you have within the healthcare system, you will see within your cities and your communities. Therefore, the messaging that we employ there has to be important. The message, who's giving the message, and how they're receiving it. And the fact that they didn't get that because it was on email is a perfect example of not thinking through how to get this life-saving medication to the people that probably need it the most.
To follow up on what Brian said, I think there are some very good examples of current discrimination in the healthcare system. Why is it that many hospitals, many teaching programs have a public service and a private service, and it won't necessarily go by those names? Very often, they will be named after somebody who was a leading academic and educator embedded in the history of the institution, and so it's sort of an honor and a privilege to be practicing on that service. But why do we have that division? And very typically, residents are given much more leeway and autonomy to practice, to learn from their mistakes on the public service, right? Who ends up on that service? It's people who are not plugged into the system, who don't have a provider in the system. Very often, they do not have health insurance, or they have Medicaid or the equivalent. And it's much more predominantly people of color. On the outpatient side, why is it those very same patients end up in the resident clinic, and then the faculty practice, quote unquote, which is people who are fully board certified, they end up with people who have private insurance, which pays more? Why does Medicaid reimburse doctors so much less for the same service? Because society values that patient less. That is why. And so we need to really reform our system, whether it's how we teach, how we care for patients, how we reimburse for care, to recognize that some lives are not less valuable than others, that all lives are valuable. And that, those are the kinds of changes that would reflect that.
I would add, if I can, that for systems that are trying to figure out, well, wow, we're doing that, and like, oh, she was talking about us, that actually, if you're going to try to embark on being about equity, social equity, health equity, racial equity, there are 3 principles that you need to check off what you're doing to see, are you doing these 3 things? Are you valuing all individuals and populations equally? Are you recognizing and rectifying historical injustices? And are you providing resources according to need? And so that's sort of a checklist that people who are really trying to be about equity can take themselves through. And then they have to be unafraid to look at their actual practice, to say, are we differentially putting some people in the resident practice and some in the faculty practice, so to have the courage to shine the bright light of inquiry, right? And then ask, why do we see the things that we see? Mechanistically, it's because of the income code that goes under or whatever. And then ask why that and why again, to get to root causes. And then to actually be willing to follow those 3 principles: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need.
Yeah, in academia, we have an excellent capacity to use fancy words to gloss over systemic racism and its impact, right? We're very good at it. We need to address it.
Brian, your sound was very strange for me. Was it strange for other people too? No?
Yeah, I think it went out a little bit, but
What did you say?
Yeah, do you want to say it again, Dr. Williams? I think it may have cut out a little bit.
I said that in academia, we are very adept at using fancy words to gloss over systemic racism and its impact. Therefore, we must fix that internally as well as externally.
Absolutely, absolutely. Shalini, any thoughts on this topic?
Really quickly, I would just say it, for me, boils down to accountability. There needs to be accountability across the board. So when there's a headline that says, regulators rarely discipline bad physicians, or state medical boards rarely protect patients, that's all contributing to the levels of trust and the challenge that lays before us when we think about how do we break that down and fix ourselves in-house before we try to, fix everything outside of the house. So I think accountability at all levels and internally and externally and all of that is important.
I think that that's such an important point, and it always brings me back to this notion that the outcomes you get are brought about by the systems that are designed to get you those. And so if the system itself is designed to get you that, and working in the healthcare system as somebody more junior, it is hard to push for accountability even as a physician in the system. And I wonder if you know, our most vulnerable patients and community members and staff are really suffering from systems like this. Who should be pushing for that accountability? Where does that responsibility lay? And maybe there's no good answer to that, but just see if you guys had any thoughts.
Well, Dr. Karan, I am so happy that we're talking this way, because, you know, we opened the framing with you know, how do we message marginalized communities, which puts all of the blame for all of this on, you know, vaccine hesitancy or distrust, or, you know, all of these things, which glorifies that problem. We have to acknowledge the history and stuff, but what we have to do is it has to do with the delivery. We haven't even written equity into our distribution plans. There was a National Academies of Sciences, Engineering, and Medicine consensus study that wrote out, you know, a framework for the equitable allocation of vaccine against COVID-19. Part of their stuff in terms of the phasing was adopted, but the hugely important part about using vulnerability indices, either CDC's social vulnerability index or a COVID community vulnerability index. So even if you're in phase 1, which is about healthcare workers and nursing homes, which nursing homes get it first, right? And so the recommendation was that states, as they got their allocations, would identify the 25% most impacted or most needy communities and send it to the nursing homes there first. What is happening in Georgia, where I am, in Florida, lots of states, is almost now a first come, first served system, right? So finally, we have the opportunity to have a national rollout plan where states are going by the same rules, and maybe we can incorporate an equity or vulnerability thing into that. But right now, you know, first come, first serve is never going to be about equity, because those people who can sit all day trying to find out who has it and sign up for an appointment or have a car to get there and all, those are the ones who are going to get it. So when we look at what's actually happening right now, people of color are lagging. It's not just because maybe they have a few more doubts or something like that. It's because the system is not trying to provide resources according to need.
So Dr. Karan, any busy leader will always say, if you're going to come to me with problems, bring me at least one solution as well. And I think we have this perfect panel here to talk about the solutions to all the problems we brought up today. Like, we have some significant historical problems, some significant problems that are ongoing right now, but we can actually talk about how do we use that knowledge to create solutions, right? Because right now is an opportunity unlike any other time in history where we can look at our healthcare system, at our social systems in regards to economics and health education and so on, and what we're going to do to transform society going forward. And we can give some interdisciplinary solutions, as was mentioned earlier, about how to make that do going forward. So, I mean, if the best time to plant a tree is 10 years ago, we need to plant our tree now for the next generation. And so when this happens again, we're not sitting here wondering how come marginalized communities do not trust the healthcare establishment. That should become a thing of the past.
Dr. Williams, what do you have in mind? You know, can we talk to each other? Like, so we're saying some things, but what would be your agenda? What would you say?
But for those of us that we're in healthcare, we're on this academic healthcare train, but there are so many smart people with solutions to problems that intersect what we deal with in healthcare. For example, our essential workers that are coming from marginalized communities. Well, they're also from the same communities that are having issues with education. Therefore, if they have to go to work, what's happening with their kids as far as childcare? If they're doing distance learning, do they have access to internet? So that's just one example of how healthcare in this pandemic is overlapping with other things that are happening within the communities. Let's talk about transportation, right? Just getting to a vaccine site. Most vaccines they're going to be given out at pharmacies and supermarkets where there's have to be pharmacies, but many of these communities, these are pharmacy deserts. They don't have supermarkets. So for us to say, yes, the vaccine is here, go to your nearest pharmacy and get the vaccine, well, that is a tremendous hurdle for many people in this country. So these are the things we should be thinking about in healthcare, because they're not on our radar every day, but they do impact the job that we are trying to do right now.
So if I could jump in on that, since I do have some insight into the Biden plan, we are very well aware of some of these pharmacy deserts. And so some of the solutions include community vaccination sites, not just the Dodger stadiums and the Fenway parks, but community vaccination sites in some of these most vulnerable, hard-hit communities that might be using recreation centers or schools, for example. We've already seen a number of schools do this in New York City. So that's one piece of it. Another is partnering with federally qualified health centers, which again are very much trusted deliverers of services in many of these communities. And finally, mobile vaccination units are also going to be a big part of the plan, in particular, but not only in rural areas, and in mapping where CVS and Walgreens, which are two of the big retail pharmacy chains that the previous administration had worked with, as well as Rite Aid and Walmart. The biggest desert, so to speak, is in the upper Midwest of the United States, which is where you have a number of Indian reservations. So really having mobile units in those areas is going to be really key. I would say there are other things we can look at, and this is kind of boring regulation kind of stuff, but it really would have an impact. Many of our academic medical centers and hospitals in general are nonprofit institutions. Why do they have nonprofit status? And should we be rethinking what are the regulations about who gets nonprofit status if they are not necessarily behaving in a way that's truly of service, of public service in their community? So I think there are things like that we can be talking about. But all of us here work at, I believe, academic medical institutions. It's very difficult to speak up about these issues. And I know, some of my colleagues who've tried to do so have been penalized in various ways for speaking up about these kinds of issues. So, I think that is a bit of the uphill battle that you're dealing with, is the very people who have some knowledge, who are inside the system, are in a difficult position to fight the system, to bring about reform, because it puts them themselves in somewhat of a precarious situation.
And there's a number of questions that are coming in here. A lot of them are very related to what we're talking about. One that I think is exceptionally relevant is, do we have examples of communities or programs that we think are doing things right, that we can kind of look to as role models for how this is working at a community level?
Well,
oh, sorry, go ahead.
Yeah, well, I was just going to start by saying tangentially that perhaps we broaden the scope to say what works well in the community, and not just where are we seeing good vaccination distribution. Because frankly, when I was reflecting on what Dr. Gounder just said, and in some places, if there's a sketchy van that comes up in the middle of a rural town and says, I'm going to shoot, give you a poke in the arm, 9 times out of 10, I think people are going to be nervous about something like that. And just to be mindful of, sometimes we don't have to reinvent the wheel, but we can also see where are the places where the community is thriving. And in the example of the pandemic, what I've seen is that mutual aid efforts have cropped up so much. I think that the ways in which our communities have creatively and inventively come together to support with food security or with financial redistribution. In Boston, I myself lead one of those kinds of initiatives, and the generosity and the commitment to one another that I've seen is quite incredible. So if we tap into what works well and couple that with some of our distribution plans, so that when there are mobile vaccination sites or when there are different ways of distributing the vaccine, we think about pairing that with what already works, you'll find that it's not a one-size-fits-all thing everywhere. It's going to be different in every community. And I think that'll be the key for us to really think about what works at the local level, what works at, in Cambridge, Massachusetts versus what works in rural Arkansas or wherever that might be. So that's what comes to mind first when you ask that question.
And it's about investing in those things that work long term. So like investing in jobs, as Dr. Gounder said before, but investing, when you find people who are trying to solve their own problems, in the long term, don't just invest with them to be vaccine partners, invest in them long term and bring their voices to the decision-making table. When you were talking about, I have always understood an inside-outside strategy too. This is going back to another point of yours, Dr. Gounder, but when those people who are of us who are inside trying to change an institution start getting suppressed, it would behoove us to have maintained a connection with the outside community so they can scream and shout and say, no, you cannot do that to that person. Meanwhile, we on the inside are using all of the knowledge and all the things we know to feed the community on the outside. There are opportunities coming in this way or whatever. And if we keep all of us, wherever we find ourselves, either inside or outside, understand that an inside-outside strategy is the strongest strategy to move all of us forward. I think that's a useful framing for all of us. Sometimes we get in there, we're trying to be part of the system, and then we get isolated from the community that might have sent us there.
And I've
Dr.
noticed,
Karan, if I can,
oh yeah, go ahead, Dr. Williams, sorry.
just really quick, if I can add to what was just said with the last couple of comments, is that I think we frequently default in this discussion to thinking about urban communities and Black and brown populations, but what we're hearing is that this is this is an issue of rural America. This is an issue of Native American reservations, as well as in urban minority communities. So what connects us all through this pandemic is much more significant and than what separates us. So this is not just an issue of urban communities. It happens coast to coast.
Absolutely, absolutely. It's so important. One of the other questions that has come up here. So there's a number of clinicians that are watching and wanted to know, for clinicians who are primarily seeing patients one-on-one and are not, maybe don't have the time in the short run to be doing as much community work just per their clinical schedule per se, what can they do? What are some of the strategies they can employ to sort of build more trust with some of the patients they see? And as you know, for a lot of us who are working in sort of internal medicine or hospitalists, we're in and out. 1 week we're in, the next week we're out, and we don't have necessarily that long-standing relationship with patients. Anything that has worked well for anybody here?
I would suggest partner institutions. So for example, I see patients at Bellevue Hospital in New York. They are recording a number of sort of Q&A kinds of things, but recording them so they're not in real time to answer questions that many of the staff have had about the vaccine. So for example, can the vaccines change your DNA? And the quick answer to that is no. But going into a brief but simple explanation, we're recording those, providing those to the staff. Those are things that really do make a difference. I think a lot of physicians are a bit older perhaps and not as social media savvy, but if you do use social media, just record, using your phone. You can just record a quick video explaining things that your patients have questions about, engage with them in a way, provide them with a way to reach out to you. One thing that I find just more generally disturbing about the PSA educational campaign approach is that is very one way. People want to feel heard. And the only way to feel heard is to give them a chance to speak. And so I think it needs to be a two-way conversation, but that's a lot of two-way conversations that need to be had. And so me going on television, I can't have all of those two-way conversations right in that 10 minutes on television. But if you can spend that 10 minutes having a couple, maybe two-way conversations with people, you have a tremendous impact in that time. So, I think sometimes we think overly big when we should just focus on the patients in front of us, the community that we're serving. And to quote what a friend of mine, this goes back to sort of college physics, but force equals mass times acceleration. We each only have so much force, but when you apply that to a much smaller group of people, you can have a huge impact. When you try to apply that force to many, many more people, your impact's just going to be a lot smaller per person. So just, do what you can in your community with the people in front of you.
Yeah, I couldn't agree more. I would say sometimes we try to think big all of the time. And if you just think small, there's that impact multiplies. I have this idea that our kitchen tables are going to be the site of the revolution. The kitchen table is going to be the locus for change. And if you're a physician, if you're a clinician, if you have conversations with patients, I've seen this done beautifully on social media. Dr. Manning actually had a 7 days of why storytelling effort. And I think that probably influenced many, many people in understanding more about the vaccine and being able to resonate with a story and being able to ask questions. And I think if we even all account for changing the mind of one person or helping someone understand one thing that they didn't know, that in and of itself is so powerful. So starting there, especially when we consider that our families are the people we trust most. And, there are physicians and nurses and people, but if we start with our families, that's a community that we've already changed for the better.
And if we ask our patients not even to think about it as a vaccine for themselves, but so that they can be around for their grandchildren, or so that they're doing it for somebody else in the family. Once we answer their questions, I remember my children, when COVID-19 first hit, they said, do not go outside of the house. These are my grown children, 24 and 30, right? Do not go outside the house. Do you know I stayed in that apartment in Cambridge for 10 weeks? Because they told me not to do that. And then I had to come home to Georgia. So I ran onto a plane and then I came home. And the reason that I got my vaccine and I was so anxious to try to arrange my vaccine is because my sister was on it. So if we have, if we can get to 1 and 1 and 1, and then also have those people communicate to their family members, do it for me. Don't even do it for yourself. We value you. I think that's a very persuasive thing. I remember the Association of Black Cardiologists, they had a slogan, every child deserves to know their grandparents. And that slogan was how they reached the older people to take their meds and stuff like that. I think that really works in communities that value family a lot.
This brings up actually a very interesting dilemma or sort of problem that's come up in the way we communicate about the vaccine right now. So as many of you probably know, we're still waiting on a little bit of data around sort of asymptomatic incidents in terms of people who've gotten the vaccine, and that brings up the question of the motivations that different people have for getting the vaccine. For some people, that motivation is to prevent severe disease in themselves. For other people, it is to prevent transmitting to their relatives. I've heard that from a lot of younger people that are getting the vaccine. And some people have felt, well, do I still have to wear a mask after I get the vaccine? And if so, why would I get this? And so it brings up an interesting question about how do we communicate about this, and what are the concerns from different communities and different people of different backgrounds, different ages, et cetera. How have you guys managed that? Has this come up pragmatically in your day-to-day life with people you know?
Well, I think it just comes up in general in healthcare in general, not just specifically for the vaccine, but all the time. We need to be able to communicate in a way that our patients understand. So that's just come with healthcare literacy and understanding that we translate our expertise into language that they can understand, but also can take action upon. So if we take that same sort of planning, understanding towards the vaccine, we have to get beyond talking about, mRNA vaccines and how that stuff kind of works, and just really explain that this will prevent you from getting a serious illness and possibly dying from COVID, and it's to your benefit as well as to your loved ones. And then who gives that message to them and how they receive it.
I found this on the web for Illness Apostle.
And I have an image. I do a lot of communication through allegory and images. So I have used the image of the vaccine. So what we have is a raging wildfire in the nation. It started out as I don't know why my camera keeps doing this, but it started out as a grease fire on somebody's stove. But since it was only affecting those people didn't put a lid on it. And so then it spread to the kitchen and the house and then the whole neighborhood and the whole city. Now the whole nation is on fire. The vaccine is like fire-resistant clothing, like firefighters wear for you at the individual level. But that's firefighters so I don't know if I disappear from the whole thing or not, but anyway, I'm still here. My computer is fighting me.
We can hear you.
Okay, but now you can't. But when firefighters have their fire-resistant equipment, they don't run to a house fire and stand around and hope that their fire resistant equipment is going to put the fire out. No, they have the fire resistant equipment at the individual level, but what they have to do is also, all of us need to become actively firefighters. What we can do as individual firefighters is wear our masks and keep our distance and wash our hands and all of that. But we really need to have the government come in with the water, and if it's a forest fire, with the helicopters and all that. And that's the thing about making it safe for most people to safely shelter in place, making workplaces safe for those who have to go, protecting workers, all of that. It is requiring all of that. So when I said before that the vaccine at the individual level is not going to be sufficient to put out this raging wildfire, that we can't vaccinate our way out of what we have right now, if I might just have 1 minute to share a riddle. This is a riddle that I didn't develop, but I love it, to help explain what exponential spread looks like. Here's the setup for the riddle. Imagine a big, big old lake. And it's just like, oh, clear lake. And you like lily pads. So you plant a lily pad in that lake, one plant, a lily pad. This lily pad doubles itself every day. So on the first day you have 1. On the second day you have 2. On the third day you have 4. On the fourth day you have 8. And so forth, 16, 32, and so forth. Here is the riddle. If the lake becomes completely covered by lily pads on day 40, on what day was it only half covered? And people start looking for their pen and paper and, how are we gonna figure this? Is it day 20, whatever? The answer is on day 39. That is what exponential spread looks like. People do not, what we are seeing with the pandemic right now is not the post-Thanksgiving or the post-Christmas surge. Yes, those things are happening, but without strong public health strategies in place, this virus is going to continue to do the one job it has, which is to replicate itself, and it is going to continue to spread exponentially if we don't put these things in place. We can vaccinate all we want to, but we are vaccinating one by one when we can get that, right? We are vaccinating arithmetically, if you will, and the virus is spreading exponentially. So I got the vaccine. Tell people that the risk benefit, there's lots we don't know about long-term side effects because we haven't even known about the virus but for a year, and the vaccines for shorter than that. So there's lots we don't know, but what we do know is that the 2 vaccines we have in the US are extremely effective. And so far the safety profile that we know is very good. And so I can live with uncertainty, right? Having taken the vaccine as opposed to the risk of dying from COVID-19 or living with long-term sequelae. So the vaccine, yes. I'm all on that. I'm not trying to get anybody off the vaccine, but the vaccine is insufficient for what we are facing right now. We cannot become so vaccine optimistic that we lose our focus on squelching this raging fire right now with the public health strategies that were neglected for a year, but now we have the opportunity to put them in place. At the individual level, mask wearing is our superpower. I thank you, President Biden, for the 100-day challenge. Mask wearing is our individual superpower.
Thank you, Dr. Jones. I couldn't agree more. I mean, it's definitely, everything you said is so true. So we've got about 5 minutes left, and I wanted to leave on one last question. So something that was brought to my attention, a lot of the time my head is just kind of focused in the science. And as I pulled my head out the other day, somebody said that what people really need right now is hope. People are exhausted. They are just so tired of this, especially people in everything, healthcare system, non-healthcare system, you name it. It's like we were hoping 2020 was going to be behind us, that 2021 was just going to be so much better, yet it just kind of feels like 2020 is continuing, except for now that the Biden administration's in, that's given a lot of people hope. But how do you guys communicate hope to the communities around you? What have you found to be helpful, and what gives you hope as we move forward here in a very challenging time?
I'm going to quote Bill Foege, who is one of the leaders of smallpox eradication. He worked both in Africa and then was one of the leaders in India as well, which was the hardest terrain in which to eradicate smallpox. He was later director of the CDC. And he has said fatalism, pessimism, skepticism, those are the greatest threats to public health, because once you give up, the game is over. So, if we really do want to get through this, we do need to keep up our hope. We do need to keep working together to move forward. And look, this is not the first pandemic that has hit humanity. There have been others. We have survived it. It is doable. but it will require a concerted effort, a unified effort together. Yes, there is a lot of hope in the fact that the Biden administration has now taken the reins. The response will be driven by science and with equity in mind. And I think that's all very promising. But there are some people who seem to think, oh, well, now that Biden's in office, everything's going to get better right away. And this is not something that is going to change overnight. And I think having some realistic expectations while maintaining hope is really what we need right now.
And I'd love for each panelist to give us their thoughts on this. Thank you, Dr. Gounder.
I'll go next. Building on what Dr. Gounder said, collective action, that we have to, what gives me hope is when people understand that we are all in this together. And I think, I don't know how people can understand that when we're in a society that's very narrowly focused on the individual, but as more and more people understand that collective action not only protects us, it propels us and it informs our path. And so I'm hopeful that we're all about to be in this together.
I think about it in three ways. I think we need three things. My recipe is acknowledgement that there have been 400,000 plus lives lost, and that deserves space for grief. That is tragedy. And that people are still enduring a very challenging, difficult, and fatal time. So acknowledgement, that is important, I think. Apology, or, hey, like if someone heard, I'm sorry that this happened, or this didn't need to happen. I think that in a way, trust building is fundamentally relational. So when Dr. Gounder said earlier, we want to be seen and heard, that is part of the recipe for hope. And then beyond that, it's accountability and action. What are the small and big ways in which we're taking action to be there for one another? And so for me, what inspires hope is my small community, the community that is coming together to redistribute money to help people who are short on rent or with groceries or with bills and utilities. And frankly, all of you, I think being in dialogue with people who have expressed consistent faith in the possibility of a better tomorrow is supportive. So those are some of my reflections on hope.
All right, Dr. Karan, I guess I'm going to be the odd person out. I probably military in me. I don't see hope as a plan. However, I am confident that we're going to come out on the other side of this. And just to, I guess, paraphrase Stacey Abrams, who said she was not optimistic, she wasn't pessimistic, she was determined. That's how I feel. I'm determined to do my part for this pandemic, and I'm confident that there are millions of people across the country that are going to do their part as well. I'm confident that we're turning the page where science and public health take precedence over personal gratification and self-dealing. We're in an area where the service of the greater good matters more. So that's why I feel confident that we're going to come out of this okay.
Absolutely. Thank you, Dr. Williams. Thank you to all the panelists. It's very humbling to be able to hear from all of you and your expertise and everything that you and even everybody listening here, everything you guys are doing is just inspiring. So with that, I would say thank you to Doctors for America and thank you to the PIRG. And I think there will be more events like this in the future where we can kind of continue these conversations. But until then, thank you again, and we'll keep pushing forward.
Thank you so
Thank
much.
Thank you, everyone. Stay safe, stay healthy. I want some autographs.